This content is editorially independent, supported by Apellis.
Hello, welcome to the New Retina Radio Journal Club with VBS. My name is Ben Young. I'm an assistant professor of ophthalmology at the KCI Institute in Portland, Oregon. And today I'm joined by Josh Uhr with Mid-Atlantic Retina in Philadelphia.
Hey, Ben, thanks for having me.
Thanks for being here. And Lediana Goduni from Retina Associates of Cleveland.
Hey, Ben, really nice to be here. Thanks.
So today we're going to discuss a paper titled Outcomes of Treatment-Resistant Neovascular Age-Related Macular Degeneration Switched from Aflibercept to Faricimab. This was written by first author Raphael Raimondi and a group from the UK, and it was published online in Ophthalmology Retina in November 2023. So to start us off with, Lediana, can I ask you to summarize the paper for us?
Yes, of course. So this paper, as you mentioned, the title is the objective of the study is to evaluate the safety and effectiveness of transitioning patients from Aflibercept to Faricimab when they had neovascular AMD with suboptimal response to treatment. This was a retrospective observational case study of 81 patients at the Sunderland Eye Infirmary in the United Kingdom. Patients were those who presented with wet AMD and were switched from Aflibercept to Faricimab between November 1st, 2022 and December 31st, 2022. All of the patients had an initial loading dose of 3 monthly injections, followed by a treat and extend regimen. The study looked at differences in response to 2 versus 3 loading injections of Faricimab at 4 weekly intervals. There were also patients that were previously receiving Aflibercept at every 6 weeks, and 7 of the patients were switched to monthly Faricimab, and 8 eyes of 7 patients were kept at every 6-week intervals with Faricimab as a switch agent. So their main findings were the central macular thickness significantly decreased from pre-switch thickness of 329 microns to 286 microns after the switch. The frequency of the presence of intraretinal fluid decreased from 46% to 28%, and the presence of subretinal fluid decreased from 70% to 30%. And all of these findings were statistically significant. Clinical improvement in OCT was noted in 80% of patients. The rest of the patients, 14% of them did not show any change in their OCT findings, and 6% of patients actually worsened when they were switched to Faricimab. ETDRS letters did not significantly change from pre-switch to post-switch. It was 65.1 prior and 65.2 after the switch. And there were no adverse events reported in this cohort of patients in the switch. So the study indicated that Faricimab is an effective alternative treatment in patients with neovascular AMD who exhibit suboptimal response or resistance to Aflibercept.
Lediana, thanks. That was a really concise, I think, summary of a pretty dense article. I think a nice summary. Josh, can you give us your kind of immediate reaction to the findings from this article?
Yeah, sure. So thank you, Lediana, for that great summary. I think that this article sort of mirrors what I've seen in my own practice. So the clinical trials for any new drug, and for Faricimab, look at treatment naive patients, and really the focus is on durability. So this is a real world study looking at previously treated, difficult to treat patients, right? Which reflects reality maybe more so than what the clinical trial populations reflect for earlier adopters of these new drugs, right? We use them in our patients that are hardest to treat. And I think that I've noticed in my practice kind of similar findings. These patients in this study, I think, received almost 30 injections prior to the switch. So these are clearly not naive patients, many of whom have probably already reached their maximal vision. So they don't really improve in the vision in this study, but they have anatomic improvement. And I've seen that, in my own patients that I've switched to. So I'm not really surprised by these results. I think it's nice to see actual data behind what I've noticed anecdotally in my practice.
Yeah, and I totally agree. I think I've seen similar in my practice too, especially like anatomic improvements. I think the visual outcomes are interesting, and that we didn't, even though there was pretty significant anatomic improvements, that there was no change or in the vision, which I think we'll want to go into in a bit. Lediana, what about you? You have similar broad takeaways as Josh?
Yeah, I think so. I very much agree with Josh. I think the results are very much in line with what I've seen, anecdotally in practice, and what other studies have shown really great anatomic improvement with faricimab, and vision sort of being either about the same, or not too much better after the switch. But like Josh said, many of these patients were treated for a long time previously, so they were active for a long time. So there's obviously some compromise in their, the maximal vision they can achieve at this point in the switch.
Yeah, for sure. So so let's go to break, and when we come back, we'll have a much more in-depth discussion about other points in the article.
This content is editorially independent, supported by Apellis.
And welcome back to the New Retina Radio Journal Club with VPS. Let's get into a longer discussion about the paper that Lediana summarized in the first part of the episode. So, I guess opening thoughts. I see a lot of strengths for this paper. It's a pretty common clinical scenario where you have someone who is, aflibercept resistant, and you want to do something for them, and faricimab is kind of the go-to at this point. But I think, and it's nice that the paper focused on those patients specifically, but I think there are also some limitations to the paper too in terms of drawing conclusions. Lediana, maybe I'll start with you. What limitations have you seen, or do you see?
Sure. Yeah. I mean, this is obviously a retrospective study. So all retrospective studies, have that limitation just by nature of being retrospective. There were 81 eyes of 64 patients in this study, so it's not a huge number. But I will say that they're looking at patients who are, resistant to Eylea. And when you look at the Eylea studies, there aren't that many patients who quote unquote fail Eylea or need it every 4 weeks. So I do think it's, for the time when the study was done, faricimab hadn't been out for that long. So getting that number, a large number of patients, may not have been possible. So they got enough eyes, to reach significance. So I do applaud them for that, but it is not a large number. Additionally, one thing that to me wasn't very clear from the paper was when the analysis after switch was done, they do mention in their treatment protocol that the assessment after the switch to faricimab was carried out 4 weeks after the injection if loaded, or at 4 weekly or 6 weeks after it receiving injections every 6 weeks. And to me, that's just a little vague about when exactly they did the analysis, but it's basically saying that it was done shortly after the switch, after just a couple injections. So the results are obviously not long-term, and they're just sort of like the immediate post-switch results. And we kind of have to keep that in mind, that, we need more data for longer term, longer results for, better conclusions.
Yeah, and I mean, I think it speaks to the effectiveness for faricimab that they're seeing it so quickly, right? And just like a couple injections is like a pretty significant anatomic effect, but not necessarily, functional benefit at that point. Josh, what do you think about their loading dose analysis? I thought that was a pretty interesting sub-analysis that in the study.
Yeah, so I agree. I thought that was very interesting because when we switch agents, I don't think there's a consensus amongst retina specialists over what protocol to follow when we do that. So do you switch and maintain the same interval? Do you switch and extend? Or do you switch and go back to the to loading doses at Q4 weeks? I think everyone does it differently. So I appreciated that they attempted to look at this question. So the way they did this analysis was they looked at patients that were treatment resistant at Q4 week Aflibercept injections. And these were truly resistant patients. They used OCT criteria for subretinal and intraretinal fluid for inclusion. So these were patients that were switched because they were really treatment resistant. And then they gave these patients either 2 loading doses at Q4 weeks or 3 loading doses. But they're small numbers. So 26 eyes received 2 loading doses and 32 eyes received 3 loading doses. And then they compared the outcomes and found that they were similar, that there was no difference. But it was unclear to me what happened after those loading doses, how far those patients were able to extend, and when the analysis was done, to Lediana's point. But still, nonetheless, to have some real data to this sort of switch protocol, I think is helpful. Helpful for us to have and to guide us, and at least to question and to discuss in forums like this what the best strategy is when we make these switches.
And
Yeah.
interestingly, it's easy to do loading doses if the patient is already coming in monthly, and that's what they did here. But they did have 16 eyes that were getting Aflibercept at every 6 weeks, and these patients were not technically loaded. They had nine eyes that they did, monthly Faricimab, and then 8 eyes that kept the interval at 6 weeks. So half of the patients that were 6 week intervals were kept at 6 week intervals, and then the nine eyes were shortened to 4. So technically, I guess that's kind of loading and dose if they're bringing back the interval down. But that's kind of an important clinical point, is that they didn't technically count them as loading doses, because if you're treating a patient and they're at a 6 week interval, it's kind of a harder sell to switch to medication when now they have to come back for 4 weeks, even though you kind of explained that might just be a temporary switch of interval until we get you dry, and then we can extend you further. So I think that was, also good that they kind of differentiated between those 2 groups of patients, because clinically, I think that's important.
Yeah. What are you guys using any particular strategy when switching in terms of loading doses? Like 2 or 3? And do you think this is going to switch your strategy? Maybe Josh, I'll start with you.
Yeah, so when I make a switch from one of the older anti-VEGFs to Faricimab, I typically don't shorten my interval. So if I'm switching because someone's at, let's say, 8 weeks on Aflibercept and they want to go longer, and so I'll switch them to Faricimab, I'll usually maintain that interval at least for an injection or 2, see how they do, and then tailor it from there and quickly extend if they're doing well at that dose. I don't go back to 4 weeks and restart the loading doses. In this case, as Lediana said, these patients were already on a 4-week interval, so it's a little more clear that you would. I think most people would just stay at that interval. But once someone's already treated for AMD, whether I'm switching or not, I don't usually go back to loading doses. I just tailor it based on their OCT. So if I switch someone from Aflibercept 4 weeks to Faricimab 4 weeks, and all the fluid resolved, I would probably extend them to 6 weeks for the next injection instead of doing consecutive loading doses at 4 weeks.
Yeah. I think that's fair. One interesting statistic though from this is, it was like 80% of patients did better, anatomically at least, and then 14% no change, but then 6% did worse. And in my practice, I have a single patient that did worse switching from Aflibercept to Faricimab, which I think is like roughly 6%, in terms of like these kinds of patients in my practice. So that kind of like, that spooked me a little bit, having that one patient, because I was doing what you were kind of doing too, Josh, but they were like Q8 week, and Aflibercept started Q8 week on Faricimab, but like, what if they're that 6% and they get worse, and let them go for a bit without it? So Lydia, do you have any thoughts on that, or like any strategies to like kind of manage that?
Yeah, I think that's a great point. I agree. When you're like at the 8 to 10 week interval and the patients, they ask if there's a newer medication where they can go longer. And we talked about this before. A lot of patients have seen commercials where, they claim to have very, very long intervals and they want new agents, and you switch them. For some patients, what I've done is, like, if they're on Eylea every 8 or 10 weeks and they want a newer agent to go even longer, I've told them that I don't know, we don't have great data on not doing loading doses. So what I've done for some patients is I'll just have them come back just for a quick OCT, and I'll tell them, like, if there's no fluid, that's fine. You don't have to get an injection, but there's always a risk, even though it's small, that you might not have the expected response. So I think you don't have to do that for every patient. I don't do that for every patient, but I think some patients, especially if they're monocular, I think it's worth to kind of just bring them in, and you don't even have to do vision unless they have a subjective change, but just do the OCT and check for fluid.
Yeah, like that, like at least for the high risk patients, because I think a lot of patients, if they've like a little bit more IRF, at 8 weeks, it's not like the end of the world. You can hopefully get it back if they're that like 6% of patients who don't respond.
Yeah.
Great. And I guess, we touched on this a bit, but it's 81 patients, which isn't bad for a pretty focused study. But it is maybe a bit smaller than some of our like big trials that we're using to inform our treatment decisions. Josh, you have any thoughts on how much we can extrapolate from like a relatively small study?
Yeah, I mean, look, I think it still gives us useful information. So these are 81 patients who were truly treatment resistant based on OCT criteria, persistent fluid at 4 and 6 weeks, and then switched to faricimab not long after faricimab became available. So in that context, it's actually not that small of a study, right? In the grand scheme of things, 81 patients is not that many eyes, but it's also not that easy to find 81 patients with this exact clinical scenario from one center. So I to their credit. So I do think that it's useful information. And I think it really provides us good evidence and data that this drug can be effective for treatment-resistant patients, because clinical trials are not designed to study that question. And so to see it in the real world in data like this, I think gives me encouragement that actually using this drug for that purpose, which I think is what most people do when a new drug becomes available, is a good strategy.
Right.
Yeah, and I think it corroborates, other studies of showing really good anatomical outcome, while vision not improving that much or kind of seeing the same. And I think it just lends more support to, obviously, what we kind of all do is just switching patients earlier. And, like we mentioned previously, these patients had almost 30 injections on average prior. So it just kind of adds more support to, switching your patients earlier, in order to maximize your visual outcomes in addition to anatomical outcomes. So I think it just adds more support for that strategy.
But then to pick at that a little bit, I'd like we've all been mentioning, the vision actually didn't improve. So how do we and the patients were still at the same injection interval too. Like by the end of the study, which again they didn't do, it was basically just like loading doses. So in this specific study, we didn't see improvement of vision, and we didn't explicitly see that the treatment interval increased. So to the patient, nothing changed. So I guess the question then is, should this be changing, or should this be promoting us to switch? I'll send it back to you, Lediana, to start on that.
I think that's a great, valid question. I think what we need is more data. I think I'd like to see a study of earlier switch patients. I mean, there's obviously a range. It was 29.4, I think, was the average, but range there. So when we have more patients or do a subgroup analysis where you have patients that were switched earlier, like let's say after 4 or 5 injections, compare those patients to the patients that waited, 29 injections. And then additionally, we need longer term data to see what they were extended to. They didn't look at, further extension. They kind of evaluated these patients right after the switch. So I'd like to see more longer term data, but I do think it's a good starting point. So
Yeah. And then Josh, maybe I'll pitch it to you, with the pretty real anatomic improvements, is like, why do you think the functional improvements really weren't shown?
Yeah, maybe for a couple of reasons. First of all, because the follow-up was short term, right? And I do wonder, we know from many previous studies that the presence of intraretinal fluid is bad for vision. So if this drug, as they show, is better at improving intraretinal fluid, presumably, although studies would need to show this, we need more data, but presumably that may mean better vision long term. So I agree with Lediana. I would like to see this longer term follow-up. The other thing, which is basically also what Lediana said, these patients are long standing. They have long-standing disease that has been treatment resistant. So they've already lost some degree of vision from that. They've had persistent fluid. Their photoreceptors are damaged. These treatment-resistant patients are the hardest patients to gain vision in. So it's a kind of self-selected difficult population to see that in.
They didn't look specifically at, if some of these patients were starting to have atrophic changes too, which, after 30 injections, we all know a lot of patients start to have some atrophy too. And obviously you have coexistence of, advanced dry and wet at the same time. So it's hard to know whether that was also a factor. That you're right, Ben, like maybe that's the best vision they can get. And that's because of other factors that, need to be further investigated.
Right. I think we all are conscious and want to avoid doing cosmetic retina injections just to make the OCT look better, right? So, but I mean, I think the results are tantalizing, and I think all the points both of you have made about how hopefully long term we would hopefully start to see maybe some functional improvements. I guess one other thing that I'll point out too is that the study, and most studies don't look at the location of the internal fluid. So if it's not in the fovea, maybe the improvement will be picked up on microperimetry or contrast sensitivity or something like that. It's just study like a practical study limitation, which is not surprising. Really appreciate both of you giving your great and deep insights into what us as retina practitioners can do with this article. And I want to thank the audience for listening to the new Retina Radio Journal Club of VBS, and hope everyone stays tuned for future episodes.